Good morning, everyone. It's an early morning session, so I think we should give another maybe 3-4 minutes for colleagues to join. Yeah. While then of course enjoy your breakfast. But at the same time, I think we have our learning brief. Walia, my district, might want to also go through that document. Your colleagues online, so we don't have anything to say at the moment. Welcome on board. So please bear with us for another 3-4 minutes. Thank you. Yes. I think we should start. Good morning, colleagues, again. My name is Dr. Om Gautam. I work for WaterAid in the UK. First of all, on behalf of WaterAid UK, FCDO, UK government, London School of Hygiene and Tropical Medicine Hygiene Hub, and Global Handwashing Partnership, I would like to welcome you all on this particular session on hygiene to prevent and respond to public health emergencies. So learning from multi-country COVID response at the scale. So today we'll be talking about at the scale hygiene response, primarily focusing on COVID pandemic, but wider learning. At the beginning, I would like to offer a little bit of context why this session is relevant and why we're coming together to present some of the extraction learning from the COVID response. As you know, virus, bacteria, protozoa never been the friend. They were always enemies. And we have witnessed so many outbreaks, epidemics, pandemics. And COVID-19 became the top 7 deadly pandemics, killed around 6.9 million people. If you look at the history, whether this is SARS, Ebola, cholera, COVID-19, hygiene became one of the key line of defense every time. For COVID-19 in particular, when it was clear that how COVID transmits from one person to another, WHO recommended to focus on 4 key behaviors at the beginning. Hand washing with soap, mask wearing, physical distancing at the beginning, also cleaning frequently the surface. When evidence were more clear that the COVID was not transmitting from the surface, of course, the 3 behaviors were the primary behaviors to focus on. Subsequently, when vaccine was found, then of course, the 4 key behaviors was recommended to promote widely. So hand washing, mask, physical distancing, and COVID vaccine uptake were the key behaviors that were recommended to promote to prevent and respond to COVID-19. It is in this context that many partners working in health and wash sector came together to respond to COVID-19, implemented large-scale behavior change program. When I say large scale, those could be at national scale, regional scale, in some cases at a global scale to capture the synthesis, learning synthesis from different contexts. So we put together this session, particularly from WaterAid, FCDO, London School of Hygiene and Tropical Medicine, to share some of our wider learning from our COVID response. So this morning, we'll spend 90 minutes together. So I'll start with the context and highlighting the agenda. This is what it is, how we are going to run through. First of all, you'll hear from me about the WaterAid overall multi-country hygiene response to COVID-19. Second, then we'll have 2 case studies from Zambia and Nigeria. One on inclusive and sustainable hand washing facilities, second on reaching the unreached during emergencies. Followed by, we'll have a presentation from Lisa from FCDO on overall learning from the large-scale hygiene response to COVID-19. Then we'll have presentation from Robert from London School of Hygiene and Tropical Medicine on the learning synthesis from the hygiene hub based on the COVID response by different implementing partners. Followed by, we'll have panel discussion. In between, we'll have, of course, the opportunity to ask a couple of questions from your end. If you have any question, colleagues online and in the room, please do write, and you can ask those questions when opportunities comes. And we'll have series of presentation at the beginning, followed by the question and answer and panel discussion. Hope everyone is good. We kick off. Yeah, good. Thank you. So first of all, I would like to focus on our hygiene response to COVID-19 at scale. So WaterAid, at the beginning of COVID response, we put hygiene as key line of defense to COVID-19. We initiated hygiene response in 26 countries, but our intensive program was focused in 9 countries subsequently, and then in 7 countries in the second year. We have targeted 120 million population in those countries. And our response was focusing on multiple settings in households, in communities, schools, public health, public places, and workplaces, including different institutions. Our desire from hygiene response was to improve behaviors. Primarily, of course, the COVID was new. People needed to know how the COVID transmits, what are the behavior they have to perform. So improving awareness and also increase COVID sensitive behaviors, and also ensuring the functionality of public hand washing facilities, thereby to contribute to reducing the spread of the COVID-19. We have spent around 9 million GBP. Donors include FCDO, Unilever, Heineken African Foundation, and others. And we have leveraged, before we start the COVID response, we have leveraged our existing hygiene behavior change campaign in multiple countries. For example, in Nepal, we have Clean Family campaign. In Pakistan, we have Clean Green. We have in Ghana, we have Clean Community campaign. Similarly, in Zambia, we have Kutuba campaign. We already had ongoing hygiene campaign. We actually leveraged those campaigns to promote COVID response. So we have phased our COVID response in 2 parts. The first phase of our program implemented in 9 countries first year. The second phase of our program was implemented in 7 countries. So the first phase was immediately after the Delta variant, and the second phase was immediately after the Omicron variant started spreading across different countries. We have focused on those 4 key behaviors at the beginning. First phase of our campaign was only 4 behaviors, including hand washing with soap, wearing masks, maintaining physical distancing, and cleaning frequently the surface. But then second phase of our campaign, the second year campaign, also included vaccine uptake. And when we are implementing community-based campaign, we haven't altered any ongoing of the hygiene response campaign. Rather, we added COVID-specific behavior within that. We have quickly applied the behavior-centered design approach. We have actually intensified to apply the evidence-based approach. In order to kick off our campaign, initially we have done the contextual analysis. We have created design principle. We have agreed on the theory of change. Then we have identified some of the key motivational drivers, the key barriers, part of our first phase program. The second phase, when we added vaccine, because some of those behaviors were new, then we have also done the formative research. Then subsequently, after formative research, then we enter into the curative phase where we have designed multiple assets, particularly for mass media, and also the community-based campaign materials, the promotional package, including nudges and cues, and also hand-washing design, part of the curative process, working with government, working with the multidisciplinary team in these countries. In terms of delivery, our campaign, first phase of our campaign was primarily focusing on mass media. The second phase of our campaign was focusing on community-based. So mass media followed by community-based campaign. And we have also installed public hand-washing facilities in different locations. And for the community-based campaign, we were actually leveraging our existing hygiene campaigns. And we have also integrated hygiene vaccine into hygiene promotion campaign. So part of evaluation. So for the first phase of our campaign, there wasn't enough time for us to set up a proper baseline and inline. Rather, we have done the midterm rapid assessment. And then in the second phase of our campaign, but we started with the thorough baseline and inline. Of course, you can expect when you start implementing mass media campaign, there was already some sort of contamination into the target population. So what I would like to quickly go through, based on our delivery touch points, I would just like to highlight some of the achievements and followed by some of the results. So in terms of achievements, our hygiene response to COVID-19 utilized mass media, digital and social media, through which we have reached 239 million population. For the mass media campaign, we have shifted our initial campaign assets were focusing on knowledge, improving raising awareness, and also communicating how disease transmit, the COVID transmit from one person to another. Followed it by we were making these the assets more emotional, using emotional drivers, including safety, including affiliation, but going beyond fear. Then, of course, throughout the COVID pandemic, there was a huge in the community, there was huge misinformation into the sector. So we thought that our assets has to be more trusted to the people and more motivational. So therefore, we started using celebrities, comedians, national athletics in order to make and the branded campaign to make our campaign more trusted to the people. We were also trying to reach hard-to-reach population through various touch points, not only to mass media, but of course, mass media is directly not reaching to the people with disabilities and people who need more attentive effort. So therefore, we use local miking, the loudspeakers, the community visits, and so forth. And also, the mass media assets also added some of the cues and illustrations rather than only the promotional the content. Our community-based response was, initially we started with the mass media. Then our community-based response was in the community. Through our community-based response, we reached 3 million population. So that was face-to-face interaction with the community people. And we were trying to maintain the fidelity using our previously designed manuals, the tools, while running hygiene sessions. There were a couple of sessions to promote behavior, including story, games, competitions, and so forth. The sessions were also implemented in schools, workplace, and healthcare facilities, primarily targeting to the frontline health workers, and also same time to the religious leaders in the religious places. And the second phase of our campaign also added vaccine. So our ongoing hygiene campaign actually added a vaccine uptake behavior alongside the hygiene behavior change promotion. Part of our response, together with the mass media campaign, also community-based campaign, we have also installed public hand-washing facilities. We have installed 3,000 public hand-washing facilities. Majority of them were permanent and semi-permanent in nature. Where temporary facilities was installed, the temporary facilities has its own operational life cycle. So that means with the daily operation and maintenance mechanism in place. Initially, we started with the food-operated hand-washing facilities because we had a fear that the COVID can transmit when they touch the tap. But when evidence are more clear, we started replacing those temporary food-operated technological options to more permanent traditional type of options. So now coming towards the end, I would like to highlight some of the results and some of the learnings. So the results, as I said, we started conducting the midterm rapid assessment. We have done midterm rapid assessment in 9 countries. We have collected data from 3,500 households, and data were collected at the country level with standardized tools, and data were actually analyzed by London School of Hygiene and Top Medicine and Rana's colleagues. Our midterm rapid assessment shows that the mass media and then community-based campaign were reaching to the targeted population. 93% of the people reported hearing some sort of the messaging. And the top 3 behavior they were hearing about hand washing, mask wearing, and maintaining physical distancing from the first phase of our campaign. As you can see here, the results, there was some improvement into the behavior. Reported behaviors were improved significantly, I would say, and the people were reporting that they started practicing behavior due to exposure with the intervention. Around 83%, 78 to 83% people reported that they started practicing these new behaviors with the exposure with the intervention. But if you look at the specific timing with the critical moments when people should wash hands, particularly linked with the COVID response, the majority of them actually washing their hands as reported after defecation before feeding. But our first phase of our campaign, the hand washing during other critical moments for COVID pandemic, particularly before leaving and entering to the home after touching frequently touch surface, were little less as compared to other critical moments. So therefore, our second phase of our campaign was trying to improve how could we actually improve those critical moments. Part of the midterm rapid assessment, we're also trying to assess what were the significant behavioral predictors, why people are practicing those behavior. And we found that the descriptive norms, so descriptive norms meaning if other people are practicing the behavior, you are likely to practice the same behaviors. So the hand washing with soap were directly associated with the descriptive norms. People are likely to practice if they see others are practicing. But whereas for mask wearing and maintaining physical distancing, people are likely to do those behaviors if people expect them to practicing those behaviors. So then also we have also assessed what motivates people to practice these behaviors. Of course, the fear was the primary motivational drivers at the beginning of the pandemic, but it wasn't because it was seen as a temporary stimulus, but the safety, the affiliation, the nurture was the primary drivers for changing the behavior. The second phase of our campaign, as I said earlier, we have done the baseline and end line. The baseline assessment was done in 1,300 households interview, but then also assessed the behavior in 650 households in 4 countries. If you look at the data, there was the increment, the change from the intervention was around 8% to 17% improved behavior. But as I said earlier, because people were already contaminated with the hygiene behavior change intervention from the first phase of the campaign. So the setting up the accurate, the baseline was very difficult for WaterAid to actually demonstrate the wider effect of our campaign. Interestingly, the other side of the coin here, the functionality of our hand washing facility from the first phase was very limited, around 25%, but we have put more emphasis on the functionality in the second phase. The functionality improved from 25% to around 75%. So what have we learned? Very briefly, so 5 key learning takeaways from our wider COVID response. 1, we have to implement science and evidence-based hygiene behavior change campaign. So that means you need to target disease-sensitive behaviors, irrespective. If you are targeting cholera, you need to focus on how cholera transmits and those behaviors. When you were focusing on COVID response, of course, we needed to focus on those specific behaviors. Rapid application of science, evidence-based, the proven approach is quite applicable and also feasible during emergency. So we should not rush without going through the process. Conducting formative research, the curative process is vital to inform the design process. And application of emotional drivers and attracting and making more attractive and context-specific the evidence is possible even during emergency. That's from the first learning point. Second, irrespective whether we are targeting during emergencies or any normal settings, we need to focus on higher reach, higher reach and exposure, and we needed to make our campaign more trusted to the people. So higher reach with repeated frequency and trust is important, so that we can use, the using celebrities, the influencer was quite key. Of course, it has a higher, it was also reduced to have a campaign fatigue. at some point. And diversity in the assets is quite important, because if you are targeting multiple people in multiple locations, it's important that you capture those wider population. The third learning was integrated programming is possible. So we have integrated the hygiene into vaccine, vaccine into hygiene, but the integrated programming needs to demonstrate the mutual benefits for both the program. The emergency response program can be more transformational. It should be more transformational. It should strengthen the system. Finally, the pre-designed inclusive technological product has to be in place. Of course, if you are installing the new facilities, the contracting take times, the inclusive technological options has to be there. Operation and maintenance is quite key. Making it inclusive and disability friendly technological options is quite key, even the emergency. We'll have some learning from the countries. And finally, the final learning points is we need to focus on inclusivity and partnership. If we are very clear that we need to reach to the on-risk population, including people with disabilities, we need to be very intentional to use the ENI frameworks in the beginning. We need to use target-focused touch points. And also the government leadership is vital to minimize, one, to of course implement at scale, second, to minimize the duplication. And partnership with the private sector is quite vital in order to bring the innovation. So those were some of the learnings from our wider COVID response. We have captured the learning into the learning brief from our first phase of our campaign. So you might have this learning brief. If not, then our colleagues will distribute. So we go through it. After this, now in the series of the presentation, I would like to invite our colleagues from Zambia, which is Walia. She is our hygiene manager in Zambia. She will be presenting our learning from the inclusive and sustainable facilities at scale. Walia, over to you.
Thank you. Well, thank you, and yes, COVID hit Zambia in March 2020, and as explained, we did use the ABCDE and leverage on the existing consumer campaign to respond. And some of the things we did were around creating a package that was focused on delivering behavior change promotion for mass media and for community interpersonal behavior change interventions. But also key to part of the things we had targeted, we wanted to reach about 70% of the population, mostly in epicenters and in 5 other regions in the country. Key to this was also making sure that we supported government with ensuring that hand washing facilities were present in institutions, because our whole campaign was centered around hand washing soap at critical moments for COVID-19 prevention. And we had to program around hand hygiene. And as said by initially the first response to COVID, when it first hit, we were all trying to get hand washing facilities, temporary hand washing facilities, foot operated hand washing facilities in the spaces. And we focused on healthcare facilities and schools where we're already working. But as COVID had in nature, we ended up working in markets, in bus stops, in ports of entry, and in some communal areas where we needed hand washing facilities and hand hygiene behavior to be practiced. As part of programming, we focused around planning. In the first phase, we quickly identified institutions that required these facilities. But later on, as I'll talk about some of the key lessons, we learned that even with planning, we had to do a bit more around community engagement, around really understanding what could really enable behavior, but also around planning for sustainability. The design, of course, in the beginning, we worked a lot with SMEs. That were already manufacturing hand washing facilities, but part of the work we did was also to try and make sure there was inclusivity. So we challenged, some of the SMEs to co-design with us hand washing facilities that had ramps, that had grab rails, and that we could be able to permanently or semi-permanently install in the facilities. Around construction and installation, we noticed an opportunity to be able to also create resilience in the communities. We had already been doing hygiene programming before COVID hit. And so for most small, medium scale businesses, there was a lot of, no business around, and we built capacity, and some of them sent them to trade schools to be able to, produce hand washing facilities as a business. And some of them are still able to do that. And some projects that we've been able to do post that period, some women groups were empowered and they've been able to assist as many as 183 schools with fabricated hand washing facilities. Operation and maintenance is key. I'll talk a little bit later as I go around the lessons, but part of the focus around scale, around inclusivity, around sustainability is that we need to be had to be quite intentional. Initially, it was about get hand washing facilities in the places, but later on when we did the midterm review, a rapid review assessment, we discovered we needed to, focus on embedding whatever work we were doing with the systems that existed and really building their capacity to be able to maintain the facilities, post the response. The other, which is quite interesting, a lot of lessons from there is around the monitoring. So you see, with hand washing facilities, we're not only focusing on, is it there, which is usually what our indicators would look for. Is the hand washing facility there? Is the soap there? Is the water there? But, we also had to look at, are people really using these hand washing facilities? Are these hand washing facilities functional to keep enabling behavior? And what sustainability frameworks are around these hand washing facilities so that they can stand the test of time? And so these are some of the types of hand washing facilities we had initially, the temporary hand washing facilities that were foot operated. The semi-permanent hand washing facility I was talking about, that was fabricated by women groups that we built capacity in. And then we moved to more permanent hand washing facilities. And of course, we were targeting a total of 600 hand washing facilities with government, but with different stakeholders coming on board and building capacity within communities, we were able to do a bit more hand washing facilities in the country, and mostly in schools and in healthcare facilities, but also in ports of entry, orphanages and safe houses where we needed hand hygiene to be practiced during COVID-19 and past that. This is just some of what we did around monitoring. And these are some of the results that we did across monitoring over the period of time. So we do what we call functionality assessment. So like I said in the beginning, when we first started out, we went back and assessed what the functionality. We assessed accessibility of the initial hand washing facilities. How clean were they? How was the operation and maintenance? Was the nudging sufficient to be able to draw people to practice hand hygiene, and around issues to do with water supply, which was usually a challenge. And if you can see, the first what we're calling LM1 was like longitudinal monitoring one, which was done in December 2021. We learned that, hand washing facility in terms of functionality, and by functionality, I mean, there's water, there's soap, and the hand washing facility is operational. We had just slightly over 50% of the hand washing facilities we had put up. At that time, we had put up over 100 and we assessed about 57. And of those facilities, only about 50, slightly half were functional. In terms of having water, soap, and being operational. With regards to accessibility, we were doing quite well, slightly above, and we would engage DPOs and we would engage different stakeholders to make sure that everybody everywhere had access to being able to wash their hands. And then things like cues and nudges, you find that we normally use the temporal ones, and you would see that only over above 50% of the facilities we had put up really had the cues and nudges in place by the time we were assessing the first round. So we did learn quite a lot. In fact, it was the first MTRA that we did that let us know that we did have scope for more permanent hand washing facilities. And so like was shared by we moved away from doing temporal hand washing facilities and more permanent hand washing facilities. And by the time it was April 2022, we had done over 400 hand washing facilities. And what we wanted to do going in the second phase was to really understand what was going on with the multitudes of hand washing facilities we had put up, so that we could program for sustainability, we could program for behavior. And the LM2, we assessed 263 hand washing facilities. And as you can see, quite disappointing results after running around and making sure that all of these institutions had hand washing facilities. Our functionality was as low as 31%. Cleanliness was, neither here nor there. The cues and nudges, surprisingly, were doing better because in the second phase, we had engaged a little bit more of the community to come up with some of the cues and install them. And of course, water supply was sort of increasing. It was, at least it was available. So we say we had to make response plans. So for the second phase, which was the last phase of the programming, we made response plans based on the results of the functionality assessment. So around functionality, what can we do? Around cleanliness, around operations and maintenance, do we have committees in place? Do we have, what are the roles and responsibilities of the different management committees in the institution? What is the RASI? Who's to be responsible? Who can be consulted? Who's to be informed? And part of this took a lot of work that, initially when you're planning around hardware, you're not thinking of so much software work that you have to do, but we had to go back and, implement tools, management models, community engagements to be able to, make sure that the next programming was meaningful. And when we did the assessment in the third time around in April this year, we did notice that because of the interventions we had put in place, quite a lot of improvement around functionality, but across the board with the things that we were looking at. So it wasn't always pitchy to be able to get to this level. We do have some challenges even around hand washing programming, issues to do with erratic supply of water, especially in some settings like markets and bus stop, but also the linkages between the duty bearers and ensuring that there's capacity within the institutions to be able to manage, also extend the management of infrastructure, not just to the infrastructure existing, but to also the hand washing facilities. So in terms of some of the things that we've learned across the assessments is that one important thing is around core design. If you notice in the processes is that initially when we started, we have hand washing facilities, this is the design, this is the standard design, and we put them out. But I think with time, we did learn that, co-designing, even with the would-be beneficiaries, is an important aspect around, being able to really encourage behavior, but also create that ownership. Around planning, things like as easy as site selection. Initially, when we went to institutions, we said, we want to put up the hand washing facilities and we'll put it up anywhere. But with time, we learned that we had to get consensus of where it would work, where it would be efficient for enabling behavior. Also, what we learned is that in as much as it's emergency, it's important that the hardware does go with behavior change promotion. In places where we made sure that we had, all of these other behavior change interventions going on, we had more use, we had better sustainability. The other key around inclusivity is what we called accessibility audits. Particularly, we had very simple tools that we were using, and we would engage DPOs. And they would, give us feedback of, the hand washing facility is not, easily used, or the ramp isn't, at the right angle. It's difficult for people living with disabilities to use these facilities. And so, it's really important when you program for hand washing facilities that are inclusive to take time to be able to get that feedback and work around it. I think the other things that are important, two last things that I'll mention is around operations and maintenance. Operations and maintenance should, ideally we would leave it to capacity building. But when you're thinking of operations and maintenance, you have to start from the beginning, establish who's responsible for what. Management models, go back to the communities, ask what would work for this particular community. And we have very interesting lessons around what works in a school and what doesn't work in a market. But it took us to go back and really engage with the would-be users and the management committees to find this out. And lastly, I think one which yesterday's session brought out somewhere else is around technical guidelines for hand washing facilities in key places. I know Zambia, part of these learnings have been taken into what we are calling the development of the roadmap, which will also see us to develop guidelines for hand washing facilities in key places. So it's just really important to have that so there's consensus and there's sense of direction on this program. Thank you very much.
Yeah. Thank you very much, Walia, for the excellent presentation. Now, moving on, so we'll have the example from Nigeria, where we'll be learning about how to reach excluded people who often exclude during this emergency. So reaching the unreached. So presentation from Wandu. She's unable to come in person, but she will be presenting. It's a recorded presentation. Hopefully, if you have any question, please save it. She will be online as well later on.
Good morning, everyone. I am Wandu, present on behalf of WaterAid Nigeria. Our hygiene response to COVID in Nigeria was aimed at improving what limited hygiene practices and vaccine compliance in selected states to meet the target of about 70 million people. We used the behavior-centered design approach as applied by to create and design and interventions that targeted key behaviors like handwashing, use of masks, vaccine uptake, and physical distancing. This presentation focuses on WaterAid's work with government to intentionally reach people with disabilities and other people who were not really considered in the COVID-19 response and did not have needed information or the support required to protect themselves against COVID-19. And it is informed by findings from a rapid assessment, rapid assessment conducted by WaterAid on COVID-19 response in some parts of Nigeria. Findings from the assessment helped us to rethink or revisit our implementation, our COVID response. And so at the planning stage, we facilitated the collaboration between government and networks of people with disabilities to make sure that they were part of government's response, contributing and bringing insights on how best to reach people with disabilities and other vulnerable groups within the states that we operate in. We incorporated the Washington questions in our baseline to better understand the types of disabilities that existed at household levels in communities. We conducted the mapping of people with disabilities and other people at household levels to understand or to know where they are, better target them during community events. This information also supported in the design of the intervention. We reviewed our assets to include people with different impairments so that it resonates with our target audience. They were also involved in the creative process. We integrated high language into TV jingles, and of course, we tested our assets with our target audience. At the implementation stage, we conducted community events in settings that are accessible to them and supported their participation at community-based events. We tracked their participation and attendance at the events as well, and conducted household visits to reinforce our message, to reinforce the content of the campaign. And of course, we're really intentional about getting their feedback to improve on how best to carry them along, how best to ensure that they participate, that not just represented, but to ensure that they participate in the intervention. Here are some of our campaign assets. It's worth noting here that what the package that was designed in terms of activities, in terms of events were inclusive. We made sure that those activities were such that people with disabilities and other people would participate and not just the spectators at community events. People with disabilities and older people represented 2% of the entire target population. And at endline, using observation and spot checks, we saw an increase of 31% in the knowledge of ways to access COVID-19 vaccine, while reported receiving early COVID-19 vaccine was at 4%. There was 38% increase in the use of face mask and 52% increase in physical distancing in public places and 44% increase in hand washing. With regards to challenges, there was really a huge dependency on caregivers to support and translate sessions to people with disabilities and to other groups. And so going forward, we now realize that they are really important in the process, and they will be trained to understand, to better understand the package. So we're sure that they are giving the person across the correct message, and that they also see the need for behavior change to happen, and they are able to better support those that they take care of, practice those target behaviors. There was also an absence of representative groups, especially for other people, and the campaign coincided with Nigeria's general elections. One of the other lessons we learned basically is to ensure that we conduct a context analysis of communities to understand the enablers to promote the practice of these behaviors by people with disabilities, different disabilities. For instance, people who use wheelchairs in a context. Some of them don't have these wheelchairs to use the crawl. How would you now target them and encourage that they wash their hands? So government realized that for people with disabilities, for people who have different disabilities, some kind of social welfare support is required as an enabler to practicing certain behaviors to protect themselves. And of course, the collaboration with influential people, celebrities, influencers, particularly religious leaders, they also helped in creating those social norms with regards to the behaviors that we're targeting to change. Thank you very much.
If you want to do great presentation. So now moving on with the series of presentation. I'm not sure whether all of you are still wake up. Sorry about that. So lots of presentation here. Moving on. So I would like to invite now Lisa Rutz from FCDO. Lisa is a WAS advisor at the FCDO, and she will be presenting on Hygiene Behaviour Change Coalition Initiative. It was a huge, large-scale initiative. So over to you, Lisa.
Good morning, everyone.
Good morning.
Yeah, I'll try to make this as kind of fun, interesting as possible. I know it's Thursday morning. Everyone survived so far this week, but yeah, jet lag was a bit tough today, I must admit. Great. So we in March 2020 well, not we, actually, my colleagues before me were racking their brains as to how do we do something that will be meaningful and at scale, given the scale of the pandemic, or that we thought it would be anyway at the beginning. We had a pre-existing partnership with Unilever on a bit of kind of market-based research and promoting kind of hand washing and hand washing products at the last mile. So based on that relationship, my colleagues and Unilever got together and they're like, what is it that we can really do that might be meaningful at that time? So we had funding available, which was great. So we gave some of that. We also obviously have a network of NGOs with whom we've worked over a number of years. Unilever have massive capacity, right? They have all of the in-kind donations. So they've got all of the products that they made available. I'll show that later, but they also have that global media expertise. They provided a media knowledge hub, help desk that NGOs could tap into with any questions, benefiting from that kind of really expert marketing expertise that you see kind of on the brands, but that we wanted to kind of use for that community-based kind of reaching those people at the community level. We worked with UN and non-governmental organizations, probably many of you here, to actually deliver what needed to be delivered on the ground, noting that obviously these were exceptional circumstances and actually access to populations was really difficult, which also set the scene for how behavior change communication was delivered. We've already mentioned several times, but London School of Hygiene and Tropical Medicine's expertise was captured through the COVID-19 Hygiene Hub, which provided access to a range of experts and academic networks. So as you can see, it was I think, a well-rounded partnership that brought together kind of that academic, the evidence, the expertise to help inform what the intervention might be, but also kind of the expertise of organizations who work with communities at the local level and with governments and national counterparts, and what I've already said. Asked me a little bit why this, whether this was kind of a unique partnership or whether it's something that can be replicated, and that's come up a number of times, and I'll sort of hope to get to that in a little bit. Just so you see what the achievements were. I won't read through this. They're massive numbers. I think the big success was reaching a huge amounts of people to really take up those essential behaviors at a time when it was, really critical to do that. So a big change, I think, was in mask wearing, hand washing as well, of course, hand washing with soap. But I think some of the other gains were really working at the healthcare facility level and extending and making that link with the communities. So I won't go through that, just to say there were two phases. Mentioned this earlier on, the kind of the earlier phase, and then the second phase that was kind of extended once Omicron hit in December 2021, was it? Yeah. And we didn't know what would happen and how fast that would spread. So we decided to extend the HVCC2, but kind of bring in the aspect of, looking ahead. How do we embed this into kind of government response mechanisms? How do we sustain some of the work that has been done on the program? And behind all of those numbers, there is huge amounts that have been learned, and I won't do a better job than my colleagues from Zambia and Nigeria to describe those. But really, just to highlight that there was incredible innovation in how these behavior-centered design approaches are delivered. Really innovative content, use of digital technologies, adaptation to kind of the changing COVID context, as we saw below. So it was constantly thinking, are our messages reaching the right people in the right way, and are they saying the right things to really get to that fundamental kind of change in practice that will make a difference on people's health. There was huge emphasis on gender and disability inclusion. Obviously, that's not always very easy to do, especially when you're looking at digital technologies, mass media, etc. But there was a huge emphasis on trying to do that well and meaningfully at the local level. When I visited Nepal, it was really interesting to see local government's role in bringing together CSOs, representatives of organizations that represent people with disabilities, and women's empowerment organizations. And that was really powerful because that creates the dialogue at the local level and really kind of, enables that to be embedded in how government might take this forward in the future. So back to, was this a unique collaboration or is this replicable? So just a few thoughts on that. So yes, it was, I think, greater than the sum of its parts. We looked a little bit at the process evaluation. London School of Hygiene and Tropical Medicine, Lauren and team made a huge effort at looking at what worked well and what were some of the challenges. It did enable a response at scale. It was evidence-driven, and I think one important point is it adapted. So we had a really strong learning forum as well. We brought together different organizations, partly through the FCDO and what we call the Behaviour Change Forum, and it enabled people from all kinds of different walks of life, I'm going to say, but different organizations, different points of view, to come together and kind of learn and discuss some of these findings, but also how to proceed. There were challenges, of course, working with Unilever, the public-private partnership in itself. It was extremely enriching. We brought together all of that, but of course we are not always equal. We don't always see things in the same way. So when it comes to, advocacy or, those external facing moments, for sure, there are times when we had to kind of agree and things like that. So that was a challenge, but all of those challenges, I think, really were totally blasted away by just the sheer kind of volume and impact of the partnership. So I think it's difficult to get these things off the ground. You do need a lot of dialogue and discussion together to make things work. But ultimately, that's it delivered massively. So that's great. So I might go through the slide, especially I've just had the 3 minutes on. So which is now 2. I think just to pick up on a couple of points on this slide. So one is, I think, really embedding kind of the formative research and how important that is at the initial stages. And even if it takes a little bit of time, to take the time to do that so that your response is meaningful. We don't want to revert back to, we've got, these set of hygiene posters and we're going to stick them up in healthcare facilities and we're going to talk a little bit to communities and think that that's going to change things. I don't think it is. I think we need to really have that purposeful strategy. And I'm not sure that we're embedding that into government systems or risk communication and community engagement strategies. Those really need to be kind of adopted at a country level in order to make sure that we're embedding some of this learning. I think knowledge platforms. So one of again, I mentioned knowledge platforms and how we learned. I think that's absolutely essential. And those can be embedded and replicated at a country level. And it is, a part of government's responsibility to make sure that they convene those types of fora. And lastly, we've heard a lot, behaviors take a long time to change. Now, I'm not sure that that's completely true. Behaviors in some cases do, but we've also seen really quick uptake. I think behaviors take a long time to become a habit, and that it's more about sustaining those. So we try to do a little bit of work on that as well through the hygiene acceleration framework tool and kind of how that's embedded at country level, etc. And obviously there's still more to do, but really important to kind of embed those lessons within government systems and processes. Thank you.
Thank you, Lisa. Thank you, Lisa. Of course, the SBCC was a unique collaboration between the donors, private sectors, and academia, as well as to the implementing partners. Thank you, Lisa, for the excellent learning extractions from there. Now, I'll make sure this is the final presentation, colleagues. So I'll have the Dr. Robert from London School of Hygiene and Tropical Medicine, and he's the director there. He'll be highlighting some of the learning reflection from the hygiene hub.
Great. Thanks, Tom. Good morning, everybody. Robert Dravovis. I'm with the London School of Hygiene and Tropical Medicine, here to talk about the COVID-19 Hygiene Hub. That was an LSHTM housed initiative that brought together partners from around the world to basically, which is all on the next slide, provide technical support and evidence-based kind of translation of rapidly changing guidelines to support implementation at a global level, at a national level, and with country partners. We had multiple channels that we were connecting from, and with partners. So just quickly in numbers, just because this is the kind of data set that we're using for the kind of key points that we'll pull together. We connected over 16 academic technical institutions. We had 65 people that served as kind of short-term temporary technical advisors on projects. We ended up providing, kind of developing over 200 technical resources for organizations to use in their COVID response programming. We also managed to kind of engage with about over 300 organizations providing either rapid technical support or about 75 where we had some kind of more long-term in-depth engagement with their COVID response programming. We also kind of through all of this managed to kind of have a website. We had over about, I think the number is closer to 700,000 right now. Which if you're an academic, you always get these like downloads of your papers, and I'll never have anything even remotely like this. So, We had an audience of about 7,000 people that we reached through webinars and about 3 million people that we connected with via social media during this period of time. So all of that, what did we actually learn if we're engaging with partners at a global scale? And this is more thinking about we've heard about specific programs. Now we're taking one step up and we looked at HBCC, which was connecting across multiple countries. Here we're now moving across the sector. What did we learn? The first thing for thinking about future outbreak and response and the OMS graphic, we saw the long history of pandemics that we've had and just, well, who knows what the next dot's going to be on that one. But a big challenge was this tendency to reinvent the wheel. We often prioritized action over reflection and didn't really build on our new experience. While SARS-CoV-2 was a new pathogen, the response was often things we already knew how to do. We knew how to do a lot of hygiene programming. We knew the necessary components around making sure people had facilities for washing hands. So we just often prioritize this quick action and assumed because we're facing a new threat, we need to nothing we've learned in the past was valid. This wasn't always the case, but it was often the case. So just thinking about opportunities to improve on this, the potential for long-term repositories for outbreak-related learning, strengthening the behavior change capacities at the national levels, both within the governments and within local response actors, and remembering some of the key principles behind behavior change. Those don't change regardless of the context. Specifically, when it comes to behavior change, some of the challenges that the COVID-19 pandemic really brought to the front, the long-term inequities in basic access to infrastructure and materials didn't magically go away. We couldn't suddenly behavioralize ourselves out of hand washing because suddenly soap wasn't magically available everywhere. There were massive efforts for distribution, but on a global scale, these inequities still maintained. There was a tendency very early in the pandemic to really focus on messaging, often health-based, over more robust behavior change strategies. And we really didn't have much information in terms of analyzing the impact of costing, of grant-making systems, or policy actions. Community engagement was another area that got better over the period of the pandemic, but wasn't that great, particularly in the initial response. This was often delayed after response programs had been designed. There was very limited support and financing. It was often on promotion or implementation rather than engagement and learning. And there were often limited technical capacity for frontline response actors to do the necessary community engagement. And finally, another key area where we saw emergent challenges globally were coordination and finance. So while there were some donors who were able to quickly leverage and release funds, this wasn't always the case. Coordination provided limited support, particularly around monitoring and evaluation of programming. So we had tons of programming, but very little ways to compare and contrast the effects of those. And typically what we did see also with this, when funds were available and widely shared, that it tended to focus on global response actors, the national level on the ground actors who really understand communities and work directly with them were often overlooked in this funding architecture. We also saw, I don't know why this is so animated, sorry. We also saw from a behavior change perspective, a very rapidly changing need. I might have said the principles of behavior change didn't change, but we got a lot of new behaviors suddenly. We knew a lot about hand washing with soap, but then suddenly as sector professionals, we had to start talking about mask use, about social distancing, which are very different behaviors, are going to require different things that are going to be driven by different factors. And then it got super complicated where they suddenly said, now promote vaccine uptake, which is a completely different set of things with a whole different set of actors. So we really were moving into a very expansive space. So, these new and novel behaviors require different intervention strategies. But BC professionals can contribute to those, provided we can remember the core principles of behavior change and really focus on those. I know we're short on time, so I'm trying to move fast. Finally, we're summing this up, we did see it wasn't all like, oh, these are the things we got wrong. It's just easy to say things where there were challenges. But we also did see that there was an opportunity for learning and innovation during this pandemic. So despite that necessity to act quickly, we were able to, not as we as a sector, not just the COVID-19 Hygiene Hub, but use this as an opportunity to better understand what works, what doesn't, and how can we innovate in our response programming. Some of these, I am quite proud of these, the COVID-19 Hygiene Hub website. We've been documenting case studies of innovative COVID response programs. I think we have about 45 of those up right now that are written by organizations, an opportunity to learn about these innovative approaches, as well as learning briefs that we've put together, which are based on direct interaction with response actors and kind of trying to capture some of those key learnings and bring those forward for kind of future pandemics as well. So this is all on our website, which I thought was on the next slide, but it's not on the next one. So when we think about kind of behavior change challenges now and in the future for response programming, I really think capacity building and capacity strengthening are really key in making sure that we're doing that at the global level, at the national level, and at the local level, and really making sure that behavior change and understanding those key principles is built into the entire kind of response system. We really do, and I think we're getting better at this, but we kind of tend to revert to bad habits when things get hectic, moving beyond information sharing and really thinking about ways that we can bring behavioral science approaches to response programming, and that really ensuring that all of this behavior change is really integrated and part of broader system strengthening efforts. I know we're all talking about system strengthening these days, but making sure that behavioral aspects of that aren't forgotten. Please do check out the website, hygienehub.info. I don't know where that came from, but cool. You can email us at support@hygienehub.info as well. And again, I'd like to thank our key partners on the Hygiene Hub. We're funded by a grant early in the pandemic from FCDO and the Bill and Melinda Gates Foundation, and really just provided a really great opportunity to kind of be able to work with partners from around the globe. So with that, thanks.
Thank you very much, Robert. Such an innovative initiative. Of course, thanks to all the funders and also to London School of Hygiene and Tropical Medicine for facilitating that unique hygiene house. Colleagues, now we want to have at least 5 to 7 minutes Q&A followed by panel discussion. If there are any questions from the floor here, and also I would also like to see the online chat as well. Any questions to any presenter so far? Yes, sir.
My question was, yes, if you can take it, I wanted to find out if you can share more with us on the vaccine promotion aspect of the promotion campaign and some of the challenges that we faced, or some of the lessons that we learned during the hiking historic vaccination. And what were some of the expectations from the taxes? And then from the Zambia organization, if there will be any lessons that you can share with us. And some of the expectations that you probably expecting from your partner, especially with the health sector, in terms of the cooperation. But I didn't see that in that part of the house.
Okay, great. So what have you learned from the integrating vaccine promotion into the hygiene promotion, how hygiene behaves in Rwanda? So that's one question. Any other question? Yes, please.
Hi, I have 2 questions. One for Lydia is, I'm interested in all of the learnings that you had around how to better support the sustained operations and management of handwashing stations. Sorry, I'm Victoria from CDC. That's something that we're also working on, trying to figure out how to share those learnings. And so I'm wondering what your approach is to both harnessing those learnings and sharing them and applying them. And then for Robert, a question about what is the future of the hygiene hub? Are there plans to keep it going? Is it going to become the outbreak hand hygiene hub or yeah, what's the future? Thanks.
Great, one more question, then we will wrap up. No, Kumar? Okay, great. So we can start from Robert then. Future of hygiene hub.
Sure, thanks, good question. So the website's not going anywhere. Seems to last forever. So it will be there, it will be a long-term repository. We have kind of gone through, we're kind of in the final stages of reviewing some of the technical resources that we wrote to kind of make them a little less COVID specific and more outbreak specific or epidemic general. Anyway, so we're generalizing some of those resources so they are transferable. But as far as kind of the providing technical support, that's something that we've been kind of winding down over the coming years. But the website's there, the infrastructure's there. If the pandemic rolls around, we're ready. So
Great, thank you. To Walia now, how could we better coordinate the learning for sustaining public and working facilities?
Okay, so for us, we took the moment. If there was a moment for hygiene work, it was during the COVID-19 response. We worked with already existing the IMF structures, but particularly the evidence that we generated from the functionality assessments, the accessibility audits. We utilized like already existing platforms like the WASH technical working groups, the RCCE, the IMF structures. And we shared some of those results. And it was interesting to hear, people from Ministry of Water telling you, oh, we really haven't thought around what should hygiene look like in, say, a school, but definitely you have something for water and sanitation. So it created those conversations, but also it's the fact that we were also starting to develop the hand hygiene roadmap. So we brought in, when we got together as stakeholders, we brought in conversation around, what does hand hygiene programming look like in the healthcare facilities sort of sorted, but in a public place, for example. And I think, bringing together stakeholders in already existing platforms, but having to now discuss what hand hygiene programming looks like, really sort of created an opportunity for the learning. Not many organizations sort of went back and did functionality assessments. So we had their ear, but also we've been able to see most of that learning being incorporated in, say, the guidelines we're developing for hand hygiene for all settings. So I think it's really about, like checking the learnings and identifying existing platforms, and then sharing those and hoping that they are, with the processes going on, they can be incorporated.
Yeah, thank you very much. The last question, the first question rather, was on what have we learned from integrating hygiene into vaccine into hygiene. So a couple of learnings from lots of institutional learning, and we actually had a recent the learning webinar among different partners who has incorporated COVID vaccine part of the hygiene promotion organized by London School and Hygiene Hub and the FCDO. A couple of learnings. One, integrating hygiene into existing behavior change campaigns is feasible, but those campaigns need to demonstrate the mutual benefits for both the programming. Otherwise, let's say government will say, why should we include hygiene into the existing already successful vaccination campaign? Similar to the behavior change side, or why should we dilute including to the vaccine? But the major learning was the success are dependent on whether vaccine is available, whether vaccine is accessible to the people. If vaccine is not available, accessible to the people, irrespective how effective your behavior change campaign is going to be, you are not going to win the race, right? The third learning was, of course, the government should take the leadership in any of these initiatives, because vaccines purely are, lots of vaccine quality issues, the delivery issues, the cold chain issues is a wider health system rather than just like adding the behavior as an additional component into the promotion. The learning from all the partners, so it is feasible to include. It is where the success are dependent, but the government leadership is quite key. If we at all need to do this based on the sensitivity if we know that vaccine is available, it has to incorporate since the beginning, since the inception of the program, so that you are rather effective when you do the formative research, the curative process, all of this can go together. And of course, if you are adding vaccines into the existing behavior change program, as Robert was also highlighting, vaccine is a complete set of different behaviors. The emotional drivers are different, the who delivers, how it will be delivered is completely different. The barriers are different. And so those has to be part of the design process so that, your campaign is effective enough to reach the target population. The couple of learning, I think that further learning, the extract from the recent discussion can also be shared, isn't it? If you want to know more on this. So with that note, I think I would now like to hand over to Aryan, and she will facilitate the panel discussion. So we'll have 20 minutes for that. All right, over to you.
I'd like to go ahead and invite all our panelists up, and as they come up, I'll just quickly introduce myself. My name is Erin Palmares. I manage the Global Handwashing Partnership. We're a public-private partnership. We advocate for hand hygiene. So, yeah, in this panel, in the short 20 minutes that we have left of the session, we'd like to dive a little bit deeper into this question on how we sustain behavior change during public health emergencies. And so I'd like to introduce and reintroduce our panelists. We have Ms. Lisa Rudge from FCDO. I'm going to try to do this in order, actually. And London School of Making Tropical Medicine. Amgatam from WaterAid, and then finally, Mr. Elijah Dara from the WaterAid Southern African region. So I want to start off with a broader question, and this can be open to any of you, but it's sort of the main question that we have. How can we achieve sustained behavior change during public health emergencies at scales? And I think elements of this question were addressed in the presentations, but just trying to tie all of this together. So really open to any of you if you have any thoughts in trying to dive a little bit deeper into what's needed. Start.
Lauren, you haven't spoken, so you want to go.
There's a lot of voice and brilliant. Yeah, so thank you for that all. Yeah, we learned a lot, I think, during the COVID-19 pandemic, but I think really reiterating what Robert said before, this isn't our first outbreak, this isn't our first epidemic. And I think what we've learned before in multiple epidemics before this as well is repetitive behavior change methodologies to kind of sustain those actions, but then to keep that reminder in place. Because we see really in the acute phase of many outbreaks, or especially disease outbreaks globally, that there's that instant lift in behavior. However, sustaining that beyond that point, to habitualize, as Lisa said, in her presentation too, takes repetitive action. And so it's thinking about the different modalities that we use and to be able to kind of think through what is, that everyone uses the phrase the enabling environment, but thinking about that kind of more holistically to keep behavior both able to be enacted, but then also kind of in people's minds in doing so. But I do think there is that challenge, and I think that was highlighted in the presentation, is that behavior can only be sustained if we have the systems in place, the physical infrastructure, the access to, say, the products and things like this, to be able to facilitate that. Because otherwise, people might know about behavior and everyone has the knowledge, but it's about what's happening there in front of your face and leading you to the bathroom itself.
Elijah?
Yeah, so I think it's one of the things is basically it has to be, let's say, government-led. We have to look at the government structure, and then build their capacity, strengthen their capacity, but also remembering the frontline workers, and that is the healthcare facilities. If you are targeting, let's say, 3 settings, the healthcare setting, the healthcare centers, you need to really focus on the healthcare workers, training them. If you are focusing on schools, you'll focus on teachers and training them. If you are focusing on community health workers, so you have a kind of a government structure systems that are already trained, and you shouldn't be rushing and just intervening without actually moving along with them. You have to train them, and they are the ones that actually should be rolling out this in communities, in healthcare workers, healthcare centers and in schools. In that way, you are able to actually impact kind of skills and the capacity for any other interventions. And we had an example like WaterAid. We had already done that when we were designing the Hygiene Behaviour Change asset. And so when COVID-19 came, it was like, I don't want to say that it was good for us, but it was like heaven really dropped something, So we just replaced some of these behaviors, which are like wearing masks. We replaced the behaviors like social distancing and all that with the previous behaviors that we had already had, like food hygiene, and so forth. And that helped us quickly to get the people we already trained, these front line workers that we had already trained, to actually quickly design the asset and tweak the assets and then roll them out.
If I could cut in as well, because Elijah, I think you make a really good point that this really should be government led. And Lisa, I know you mentioned this a little bit in your presentation, but FCDO has been working through its partners with government. So I'm curious if you could speak a little bit more on the role of government and sort of looking at the from systems lens.
Yeah, thanks. So yeah, I mean, how can I start? So firstly, I think, yeah, absolutely. I think firstly, government has obviously has overall responsibility, as was just said, but also has that convening power and the mandate across different levels of government, national, subnational, and allocates roles and responsibilities in the system, right? So it's really important that they have a clear strategy and vision of how to embed hand hygiene or hygiene more broadly within the system. That means that it has to be thought through in a collaborative way. So often hygiene is the remit across different actors. So it's with the Ministry of Health, but it's also sometimes with local government, municipalities, depending on what type of hygiene we're speaking of. So it's really important that there is a strong strategic approach that is evidence informed. We know that. And then I guess what we're thinking through at the moment is how do we as development partners or external actors support those things, right? Through TA, through knowledge networks, through sharing the evidence and supporting kind of those interventions. So I think that's really important. Yeah, I think I've covered most of my points. Sorry, I did have one other point, which has now escaped. It might come back to me later, but thanks. Yeah, those were initial reflections.
Yeah, thanks, Lisa. I think that also brings up, sort of the lessons learned. And I know in your presentation, you sort of shared a lot of the approaches that WaterAid has taken for behavior change at scale. And we saw, especially around COVID-19, the use of behavior-centered design. So just curious if you could share a little bit more on how you stepped up and some of the lessons learned from your work.
Thank you very much, Arian. So WaterAid, we used to be using the behavior-centered design approach all across our country programs before the COVID-19. When COVID hit, at the beginning of the response, so we're thinking whether we follow the standard approach, any evidence-based approach, because it was quite rushed program. The intervention was quite needed on the ground on the second very day when we decided, oh, let's respond as an institution. We thought that, I think we already had lots of learning. What happens if we don't follow standard evidence-led behavior-centric approach? That might sort of quickly create the fatigue. That may not be more evidence-led. The people may not like the intervention, irrespective how much you are going to invest, that it's not going to work. So rather we then thought, okay, so can we quickly amplify or rather rapidly apply the behavior-centered design approach. So rather than taking, let's say, 3 months conducting formative research, we then shorten down to 15 days of formative research, just to understand what are the additional key drivers, what are the key barriers for those additional behaviors that we needed to promote. So rather than doing nothing, I think the utilization of the behavior-centered design approach actually help us to understand the behavioral determinants more closely, including to the vaccines, for example. Of course, utilizing any framework like behavior-centered design actually help you to go through the process. So you can actually standardize different level of the evidence, but at the same time, the process actually help you to design robust campaign. For example, the C is all about create, where the behavior-centered design approach demands that don't design any intervention based on your expert thinking. Don't design in the room. At least have a curative process. Bring multidisciplinary team who understand the science, who understand the social marketing approach, who understand behavior center approach, right? So we have gone through those processes so that at least rather than designing the content from expert thinking, it was more on evidence-led, more context specific, and also target sensitive, because designing any content to focusing on target audience should also represent their insights into the assets, into the promotion, and so forth. So it was quite helpful to utilize the behavior-centered design approach through that point. And the behavior-centered design approach also has elements of delivery and evaluation. So it helps. How do you actually maintain the fidelity of your campaign? If you need to deliver, then you need to be consistently deliver a design. Is for design. So if you don't follow the process, what happens? You might end up kind of making your intervention exciting in one cluster versus in other clusters. So following same principles, same design principle actually help you to standardize all across, and you build the capacity of the frontline workers so that you maintain the fidelity all across. And finally, because the behavior-centered design approach also has key elements. So of course, at the beginning, because Lisa is here, who funded the majority of our program, and there wasn't any demand from the donor side for the first phase of the campaign. Oh, don't start the campaign without setting up a baseline, because it was much necessary intervention we needed to kick off on the ground right away. But having that approach in mind, we at least have done the behavior side, the midterm rapid assessment. We actually help us to reform our program for the second phase. And second phase, when FCDO came along for the second phase of the campaign, and then of course there was kind of a request from the donor side also. Can we do baseline and end line? Can we see the effectiveness of our program to see whether this alters any behaviors, right? So I think having standard approach actually help us to standardize the process a lot less. But at the same time, I think if you're dealing with multi-country initiatives, you need to have certain principles that come across all the countries so that you can compare results, you can share learnings, you can also, the plan for cluster learning documentation. So yeah, so having specific approach actually help in many ways. To inform your evidence-based programming.
Yeah.
Thank you.
No, that's great. Thanks, Tom. And it definitely makes sense to have that standard approach. I'm glad that WaterAid already had that system in place. I think you also brought up an important point on it's both delivery and evaluation. So Lauren, I want to turn it to you because I think monitoring and evaluation is always a question when we're thinking of program design and implementation, but how is that monitored and evaluated? So can you speak a little bit on how we can monitor and evaluate these behavior change programs, especially in emergencies, and also how we might harmonize some of these indicators for hand hygiene measurement?
Sure, and I think so monitoring and evaluating behavioral outcomes within any setting still follows the same principles, right? It's about really selecting the target behaviors. And I think sometimes we have to think back to specifically with COVID-19, we were overwhelmed with the number of behaviors perhaps, and we were overwhelmed that this is all novel. And actually we had very specific behaviors that we wanted to address with our campaigns, but also that we wanted to measure. But it's reminding ourselves that kind of reduce that list down, reduce the list down to make it a really targeted behavior till you're actually assessing those outcomes. Again, thinking about, and it was really lovely to see the presentation from Nigeria, it's about which groups that you're actually addressing as well. So again, they had a lovely presentation about kind of people with disabilities. So identifying the behaviors within a specific group. Again, we're just refining that and we're refining our terminology. But these principles aren't just within public health emergencies. These are the same for any behavioral outcomes within any set of programs. But then you can start to think through the design, and that's really the capacity of the organization. Thinking the types of data that they're going to be collecting, kind of is it going to be self-reported behaviors that we saw kind of across some of the programs that were given today, or is it going to be observed into that extent of measurement? But then there's other things that we have to think about that allow us to understand perhaps why we don't see any behavioral outcome or change in behavioral outcomes, so the factors that influence them and kind of contribute to that system. And I think it's really important to kind of reflect on that and just not get overwhelmed with all of the things that we could measure, just to really refine that list down. But again, I really want to repeat, this isn't particular to public health emergencies. We just get a bit kind of probably worked up because we have to act at speed when all of these principles are already known within kind of behavior change kind of evaluations already. I think I really want to talk to the considerations within this program, and I'll just kind of said it here there. Is in phase one of the HBCC program, it was rapid response, and we were really focused on outputs, and we were saying how much has been delivered, and you saw the massive numbers, the reach and the products distributed. And that was really key in understanding, just get everything out there. We need to kind of be, life-saving mode. But when phase 2 came around, we really wanted to understand the outcomes of the program. And I think that was really key to the partnership, and it lended itself well to having kind of a donor-led organization, NGOs, and then an academic partnership, because we were all wanting to do it. So it wasn't just that the donor was demanding, the donors were demanding that we had to do outcome ascertainment, is that the partners themselves also wanted to do so, but you also had the kind of, academic addition to that partnership that helped curate, that helped kind of formulate some of the outcomes that we wanted to look at. I'm not even going to lie, it was very hard. I had 10 organizations that we had to work with, all who have lots of personalities and lots of countries, and I had to get them all to measure exactly the same outcomes. And that's a huge amount of work, and it was lots of conversations, and at times I think everybody hated me, but then they all loved me in the end, so it's fine. It's a real story of success, and at least my personality. but that was kind of like getting us on board, but it really took a lot of alignment to get everybody within that and to identify that we were in the same partnership, and that's not always the case. And in this instance, we didn't work directly with the government. So, I'm still talking from a biased response here that was, okay, we've got a bilateral donor, we've got a UK institution, and we've got the NGO groups. I don't know what that conversation would have looked like if we were asking the government to also measure the same behavioural outcomes and within their systems. There's a few things there. I'm going to also lend it to this idea that sometimes, again, we get overwhelmed with the scale, perhaps, of measurement. And so it's quite useful to think about and reflect on kind of the skills that you have within your organization to then determine the scale in which you're going to measure some of these outcomes. I'm not asking you to measure across 20,000 people what the change in behaviours were, but thinking about what's actually feasible, because sometimes you can fit it in your program to measure all the way to outcomes. And I think it's a conversation that I think hopefully has been happening in the last couple of days. But outcome ascertainment and outcome measurement is really important, because we can't just keep measuring outputs and what we've delivered and nothing else, because like everyone's talking about system strengthening now, we don't know how then it's contributing to the systems change. So I'm just doing lots of plugs for keeping us employed, but yeah, so yeah.
Thank you. And I think your last point too on really looking at the existing skill set, and Elijah, I know that you have experience from your work. We all know that it's only a matter of time until the next public health emergency. And Lauren kind of hinted on this, and also you hinted on it in your initial marks, but can you speak on the importance of capacity building as part of this to not only prevent, but also sort of institutionalize hand hygiene in the future? What's your experience on the ground?
Yeah, thanks a lot. Yeah, as I said before, and I will be very brief. We initially, it was like we had already this huge multi-country hygiene behavior change intervention that we had done in Malawi, Zambia, Mozambique, Madagascar. And I think Home had mentioned we had even a national kind of campaign. Like Zambia, it was October campaign, which means I think hygiene is cleanliness is life. And then in Mozambique, we had already a design called Bye Bye Cholera, because we intervened in the cholera campaign in one of the districts called Kwamba. And then also in Malawi, we had a clean campaign. And then also in Eswatini, Madagascar, we had a shining campaign. Actually, those were already there. So when this issue came, what we did during those campaigns, first of all, we had 5 days workshop. And those 5 days workshop, 2 days were just meant for the training, just training. And the participants were diverse. So we had government, national government officials, local government officials, health workers, teachers, and so forth. And also other NGOs, like other counterparts were also participating in that. After that training, we selected QTs. For 3 days, we then went through a vigorous design of the hygiene behavior change assets, the design, because they already knew how to, they were trained, and therefore the design. And these are the same people again that once the tools have been developed, we gave them the tools, and they are going to train. Let's say if they're teachers in the school settings, they're going to train other teachers to be able to roll this out to other schools. We with healthcare workers, we trained some of the nurses, they were then going to train others to roll these tools out. So what we did during the COVID when COVID came in 2020, we just replaced it was very easy to reactivate this platform, this trainer, the people we had already trained. And then what we did is just to replace the other behaviors like what we trained them on food hygiene, we trained them on water treatment and storage behavior, toilet cleanliness and all that. We now replace social distancing and we brought in wearing masks so that we can then tweak it to make it COVID-19 sensitive behavior. And based on that, it was very easy for these government officials and targeted people that were already trained to quickly just actually run with it and start rolling out the behavior. And especially the community-based intervention was very much well done because most of these healthcare workers, community workers were already trained and they just trickled out the different behaviors. So it works actually very well. My take away would be, we need to make sure that we use the existing structures and especially government structure at both levels, provincial, national, provincial, and local levels. And then also we have to target different settings, the frontline workers, like healthcare workers and all that. Very important. And once you do all this, you're kind of institutionalizing the capacity. And therefore, any eventuality or any kind of COVID-19 or any pandemic coming in, you just activate that platform. Right now, as we speak, just the last point, you find that the government officials used to use only leaflets. They go for hygiene leaflets, they put there on the wall. Right now, they are actually producing tools, the assets, and games, which are almost indicating all those tools. And they are very enthusiastic and they are thinking that they are working. So these are some of the things that we need to be able to do. Thank you.
Alicia. I know we're at time, so I won't ask any other questions. If there are any final remarks that we didn't get to in this panel, maybe in 30 seconds, you can wrap it up and then we'll go ahead and close.
Sorry, like 2 points. One is GIZ did an amazing work at developing a massive online course through the Ministry of Education that was embedded in the Ministry of Education and is available to kind of adapt.
I'm being presented later today.
Oh, okay, great. Well, there you go. So do go join. And just last point, hand hygiene guidelines coming up from WHO and how do we implement them? So I guess just a call to say, those will be really useful in taking forward those discussions, how to embed those, identify roles and responsibilities and embed them in the system, but also, remind governments that there is a cost to this, that it doesn't happen by itself. You have to embed these things in your budgets, in your planning processes at every single level. Otherwise that will get forgotten. So thanks.
And just a note that we did have a session yesterday on the hand hygiene guidelines, and we'll have an event summary on our website in the next coming weeks. So if you missed that session, we'll have that summary reports. But just a big thank you to our panelists, our presenters, and to you all for joining us this morning. I won't keep you any longer because I can see tired faces
And everyone's like,
coffee. So thanks, everyone.
Sorry, I just nice to see you. Great.
Hi, I just wanted to say thank you for that last note that you did, because what we've been doing at Habitat from the beginning, we're going to make a plan and actually look at how much is it gonna cost over time for this to maintain. Yeah. Yeah. And at every level, on the community level, the government, I don't care if it's a piecemeal budget. This has to be maintained. Otherwise, they're gonna be standing there. Yeah. And they're not gonna be used. So thank you so much.
Yeah, no worries. Yeah. It's so otherwise, it's just gonna happen. Like,
No.
Yes.
It was very much, you know, they created one.